Can you drop the fluoro? So, picking back up, we are trying to get in, but there's so much arthritis here at 5-1, I'm not able to navigate past it. Shot. No, you're doing good. She's doing her best. Huh? What did she say? Just her back, right? Shot. 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 I'm just not getting around the facet. That's the problem. Let's go with an AP. Yeah, see the bone right there at the tip of the needle? Let's go back to a lateral. Let's do some orbit. I think you took the orbit away. Try the other way. More. Doesn't look that bad on this view. There we go. That's it right there. Now the wag. I wonder if we can improve the wag a little bit. You can see we're right at the superior facet of S1. Huh? I can't tell either. Try. That's definitely worse. So we're trying to optimize the x-ray view through the patient. And it's a process of going a little bit more in one direction than another. No, that's worse. We had it better before, I think. No, that actually seems worse, right, Luis? It's hard to tell because the pedicle looks better, but the sacrum looks worse. That's because of the scoliosis between the two of them. Keep going. Let's see what we can find. I want to see if we can even out the end plate of L5 and S1. Keep going. Look at those facets, how arthritic they are. Oh, that's interesting. Isn't that interesting there? That's brought the L5 end plate across. Let's go north and then give me some more wag that direction, the same direction. So we're trying to optimize our x-ray so we have a better view. But it's so hard because her bone density is poor, plus she has a lot of soft tissues that reduce the penetrability of the x-rays, and we have the very best x-ray machine for the OR. You had it better before. No, it's getting worse. So if you do navigation of the spine with an x-ray, that's almost really good. Keep coming that direction. If you do this, that's really good. But you've got way too much hip. So you're going to have to bring the whole base north and then wag again all this side south. Nope, keep going. I need more wag south on my side. I think that may be our... What do you think?
That's definitely better.
Yeah? I think we can do better. Let's bring the base a little more north and wag my side south. Alright. And bring my side south. Look at the bottom end plate of 5. See if you can line it up like you had it before. It's really close. You're about a degree off. And I think that's probably it right there. That's probably the best we're going to get it right there. I need to come south. Let's, you have another needle?
I have another needle, please. Final needle, please. Thank you.
Let's get rid of that one.
This one or this one? You don't want this one?
We have a needle on the floor. Use your gloves. You can pick it up and throw it in the sharps container. One needle off the field. Thanks. All right, let's try this again. I wonder if this one, that was the one we went through before. All right, don't move, okay? May even be able to be a little bit lower than that. How's she doing? I just need her to lay still while I get down here. We now have that disc lined up the best we've had it. I just need you to lay still, sweetie. Yeah, this is where all your arthritis is. And it's thick. Let's get an AP. See where we are in the AP. I mean, our WAG is good still, even though she moved. But I think our orbit could be improved. So I'm a little too medial. Let's go back to a lateral view. I want to get a little bit lower and sneak around that facet. Yep. All right. WAG looks good. Let's do some orbital changes. Let's just do a degree. Your side up. No or yes? Shot? Gosh, it didn't make a difference. I don't know. I can't really tell. It looks like it's getting worse. What do you think, Luis?
Yeah, that's better. More.
Let's see. Try a little more. That may be better, actually. You may be right. Keep going. Yeah. That's actually... Geez, I think that's the best we've got. Now if we could just keep everything. I need you to try to lay still, okay? I can see very clearly where we need to be. Clear as mud. Just kidding. Better than mud. Look at all that arthritis right in front of the needle. Amazing, huh? Shot. Don't sit up. Shot. Yeah, you're doing real good. This is the worst part of the surgery. If we can get past this, it'll be really good. Shot. Right on target there. You see that? Nice trajectory. We just got to get around this ginormous facet. That's the problem. It's the facet. Shot. Shot. Still. Yeah, you be patient. You're doing good. If we get this done, it'll be worth it. Trust me. By the way, for those of you wondering, it normally takes about a minute to get into the disc. But because her bone is slipping forward, L5-S1, because of the scoliosis, shot, because of the arthritis, you can see right there where the needle is in the facet joints, because of all this stuff, it's all made it so hard. You okay? How is she? I think I might have found the path. Maybe. Hard to say. It's not even a millimeter. It's less than a millimeter path. I can just feel it compressing this needle. Wow. Oh, yeah. Shot, please. Amazing if... Well, shot. We're right there. It doesn't get any closer than that. How you feeling? Huh? Peachy? Oh, we're so close. I think we've got it, but I'm not 100% sure yet. I need to be 100%. It's right there. So what I'd like to do right now is to do an AP. Let's see where we are. If I'm where I think we are, we can get in there when she's asleep, you know? Yeah, don't move. We've come so far. Oh yeah, we're right there. That's perfect. We're gonna get this done. I'm actually excited. I have to give that probably the hardest one I've done. Easily the hardest one I've done. That's the hardest I've ever done. There's no doubt about it. Now if I just get all the way in, we can do a nice discogram, and I'm probably sitting right on the top of the sacrum. Right there. Or she's just compressing on her disc so hard. You know what I mean? That I just cannot get past this little brim of bone. So I'm not going to be able to do a discogram. Let's see if I can just finesse it. This is finessing. This is finessing. It's no joke. This is the finesse of finesses. I'm not trying to toot my own horn, but anyone who does IPM, interventional pain management, and has ever had to go foramen, you know what I'm talking about. This is a tough one. Okay. Let's get an AP. I'm happy with the position. I think we're safe. We're under the nerve root. Unfortunately, I can't get a discogram, but that's all right. Yeah, that's perfect. It's really nice on the x-ray. I feel like I'm right there. It's so hard not to just try to get a little bit further so we can get a discogram. You okay? We're going to put you to sleep, and when you wake up, we'll be done. All right? I just won't be able to test if that's your painful disc, but I know it is, and I know it's hitting the nerve, so we're ready. Just take your time. I want you to count from 1 to 100, okay? Can you do that? Out loud. I can't do a discogram. I'm not in. I'm just right behind it. Nice and loud so we can hear you. Keep going. Keep going. Yep, you're doing good. Shot. Nice and loud. Well, so for those of you watching, this is truly, I mean, up there, top shot. Hardest I've ever done, because I can literally feel how tight it is coming down the foramen. It's squeezing the needle, and this is an 18 gauge spinal needle. Like, there's no room at all. I had to make room. So just got to be really careful not to take this out, the guide wire. I got to leave the guide wire as I'm bringing out the needle. You can see the tip of the guide wire sitting right there at the back of the disc. I think we're going to be fine with the dilator. The dilator, when she's asleep, will spread open the disc, and it'll let me in. But it's not going to be easy. Just take your time, Dr. Rafferty. Okay? I'd rather her be a little light and moving a little bit than too deep. Okay. And 7mm cut. Now through this cut, we're going to bring the dilator. The dilator just spreads the tissues. Okay. So shot, I want to really be sure not to move my guide wire while I'm doing this. I want to make sure she's comfortable, the patient's comfortable enough. And we're going to get down. Shot. If you're not careful, you can actually pull your guide wire out. Shot. So I got to keep a close eye on the guide wire. And we're going to get to that facet, and it's going to get tight and ugly. Like right now, I can feel it. We're right on the facet joint. This is where all the arthritis in the facet joint starts. We're not here to fix a facet joint. Okay? There's a lot of things going on her back. She's got degenerative disc disease, all the discs in her lower back. She's got at least 6 or 7 discs with degeneration. She's got severe scoliosis. She's got facet arthropathy. And she's got stenosis. She's got degenerative disc disease. She's got everything. So we've got to be just really careful. We're here to fix one thing, and that's a herniated disc at L5-S1 that's causing pressure on her nerve root, causing some nerve damage. So we need that fixed. She didn't want to have open surgery. She didn't want a microdiscectomy. How's she doing? This is going better than I thought it would, so I'm almost there. I just need her nice and relaxed for a little longer. There's the guide wire tip. We're just about there. And to those of you watching, it may look like we're going right through the back of the spine, but we're not. We are actually going through the side. And there's a little hole where the nerve comes out, and that's where we're going, just underneath that nerve. Shot. Making gradual progress. The reason I'm struggling a little here is because the actual tip of the guide wire is sticking out, and I can't just hit it. I need to hit around it. I'm not quite in the disc yet, so I can't take it out. Should be getting closer. Millimeter at a time. it right there, huh? I'm not quite ready yet. Very close. Shot. How's she? How is she? All right, just about there. I'd like to get it a little bit further along before I pull that guide wire, you know? But maybe that's the best I can do, given the circumstances. I don't want to pinch the guide wire, because then you could fracture it. Shot? My gosh, that was beautiful. Very fortunate. We're in. We're in like Flynn. Okay, well, I gotta be honest with you. About 20 minutes ago, I didn't think we'd make it this far. I was really worried because I was really struggling to get to the L5-S1. L5-S1 is the hardest by far. Good. L5-S1 is 100% the hardest. And this was a, what do they call it, wall banger? This was as bad as it gets. I think a wall banger is a drink, right? So we stuck it out and got it. We're going to get it done for you when you're watching this. Yeah, so the dilator is going forward. We want to stop it before it goes too far. Yeah, go ahead. Just keep an eye on the tube while you're doing that to make sure the tube doesn't come out. You got to kind of hold the tube with your finger and kind of twist it. Yep. How's that? Feel it moving?
Yeah.
Uh-huh. Keep going.
Again.
Oh, beautiful. Yeah, you can take it out. You can take it out. Yep, we got our tube in far enough. We had a patient just a few weeks ago that was so big and strong that his spine literally crushed the tube. 2 tubes, right? We lost 2 tubes that day. He was Canadian, and his discs were so collapsed and the bones were so tight together from all the scar tissue. Yeah, that's it right there. You see it right there? See it? I think it's there, right? Yeah, you're right. It's on the other side.
Okay. Is over there?
I'll twist it.
Okay.
So we lost 2 tubes that day in surgery because he had a 5-level surgery done. All right, this wasn't so bad. I was able to rotate it. And you bought more of the tubes, right?
Oh yeah.
Yeah.
I bought 6.
Yeah, good. I want plenty of them. I never want to have us to abort a surgery because we don't have enough tubes. All right, so here we go. This is endoscopic Deuk laser disc repair. For those of you wondering, again, we got, if you've been watching this whole time, I know we had a transmission break, but we had some technical issues with the broadcast, but long story short, we finally got here. And I got to give credit to my team. Jordan, great work on the fluoro. Luis, good help. We're inside the disc. Now there's no blue dye because we didn't inject it, because I couldn't get inside enough to do the dye, to do the discogram. And there's just so much inflammation with this patient that you can see there's a little bit of capillary bleeding from all the inflamed tissue. I'm going to bring the laser in. And what we're dealing with at 3 o'clock is the end plate of the bone. And that's the annular tear. That's the laser, the blue thing. Okay, you guys ready? Boys and girls? Everybody ready?
Rita, can you turn off this light, please?
Do we have the pump going, Rita?
Yeah.
Thanks. Perfect. Air bubbles just come from the bag. All right. And of course, as though it wasn't hard enough to do the surgery, we have to have a little bit of bleeding. Very minimal. If you've ever been a diabetic and you have to prick your finger to check your blood glucose, that's about how much bleeding there is. So it's really very minimal. Let me turn off the laser. This is some of the herniated disc is now inside the disc. That's the beauty of this procedure. And this particular part of the procedure was taught to me by Dr. Anthony Young. Dr. Young taught me to do the inside out. Lay still, you're fine. Taught me to do the inside out technique, where we start on the inside and we work our way out. So what you do is you're pushing the herniation back into the disc. All right. Any questions from our viewers?
Yes, we got our first question from YouTube. He says that he's having an MRI. He had an MRI 9 months ago, and he needs it to get updated. What should he tell his radiologist back home?
So somebody had an MRI 9 months ago, and they want to update it. So there's really, between you and I, there's no reason to get a new MRI. MRIs are good for about a year when it's the spine, unless, of course, you have a new injury. So if you've gotten a new injury in those 9 months, then yeah, a new MRI is a good idea. What I would tell the doctor is, hey, I have a new injury, I have new symptoms or worsening symptoms. And then what they can do is they'll order the MRI for you. But there's no reason to get another MRI unless you actually have worsening symptoms or you have a new traumatic injury to your spine.
Another comment on YouTube says he's getting a cervical fusion done from the front.
Yeah.
Why do you use the front over the back?
Okay, so I heard just the first part. Somebody's getting a cervical fusion called an anterior cervical
Yes.
discectomy and fusion, or ACDF.
Yes, and he's having it done from the front.
Oh,
Why do people use the front instead of the back?
Yeah, great question. So the problem with your spine and everybody else's spine that needs a cervical fusion is that you have what's called a disc herniation. And the problem is in the back of the disc. The back of the disc is still considered the front part of the spine. And basically, the herniation at the back of the disc, or bone spur, whatever's back there, disc osteophyte complex, that's pressing on the nerve or spinal cord, the way the surgeon gets to it, since it's in the front of the spine, in front of the spinal cord, you have to go through the front. That's the safest, best way to do it. That's the standard of care, the standard treatment, is to go through the front. Now, I'll go through the back of the neck and the back of the spine when there are 4 or more bad discs that need to be treated. So if the patient only has 1, 2, or 3 herniated discs that need treatment, I'll go through the front, just like most surgeons would. And then if there's a 4th disc or more, 4th or 5th disc that need treatment, I go through the back. And it's just because it's safer going through the back at that point. You do a laminectomy and a foraminotomy, and then you fuse. And we were supposed to do that surgery today, but we actually canceled it. Stand by, grab her, because the patient was having some respiratory issues, and we want to get that patient checked out first. So, all right, you can't twist it off my finger. It doesn't work that way. All right, we did not use the blue dye again. We did not do a discogram because I couldn't get the needle to advance past just the back of the disc. But you can see normally all this stuff would be stained blue because it's all herniated disc with scar tissue. If you're able to come by and get a laser surgery done here, that's better than a fusion on your neck. Just if it's possible. Fusion is so permanent and you're losing movement. You're fusing two bones that are supposed to move. And if you have a 2-level fusion, you're fusing 3 bones that are supposed to move. And if you're having a 3-level fusion, you're fusing 4 bones that are supposed to move. So you're actually permanently taking away what God gave you at birth, which is movement at your discs. This woman that we're treating right now, L5-S1 with the laser, I'm repairing her disc so that she can keep the movement in her back. We don't want to take away people's spinal movement. The spine was built and designed to allow bending and twisting, and we want to preserve movement. So we do repairs of the disc rather than fusing. It's not that I can't do a fusion. I can very easily do a fusion. But we choose not to because this surgery is better than fusion. You don't want to do a fusion unless you absolutely have to. So I hope I answered your question, but at the same time I hope I got you to start thinking about maybe not doing a fusion. There's really very few things in life that are as permanent as a fusion. Even marriage is not as permanent as a fusion, right? I mean, you can end your marriage, but easier than you can end a fusion. Fusion's impossible to go back and put movement back in. There are people that are selling the idea of reversing fusions these days, but it's all nonsense. There's a reason why. They may be able to take your fusion mass out and drill it away and put an artificial disc in, but what they can't undo is the fusion of the posterior elements, which is the facet joints. So if you look at their pictures, they talk about, and this is a good one for spine scams, Diego. They talk about how they can reverse a fusion, but they really can't, because you're not reversing the fusion of the posterior elements that was done during the ACDF. Your ACDF is a fusion of the inner body, but ultimately the posterior elements fuse as well. And that cannot be undone. There is no technology for that. So the laser is zapping away the herniation right now. And it's painstaking, takes a long time. This is a really, really scarred up piece of herniation. It's really, really, all this stuff that the laser's blasting and it barely goes away, scar tissue. And the golden color you're barely seeing there is calcium. It's basically bone spurs. Almost done. This is a big piece of herniation. Look how scarred up it is. All this white stuff I'm zapping is scar tissue. So this is our last surgery for the day. And we've just got a lot of water coming down. Why is that? I think we're not trapping it properly here. Okay. All right.
We have a question from Facebook.
Sure.
A patient is scheduled to have an injection on L5-S1. She is very nervous about it and wants to know, will that help with her disc pain? And is it as painful as an epidural?
Oh, hey. All right, great question. So, first of all, they're having an injection at the L5-S1. It sounds like the injection is an epidural. Maybe I'm mistaken, but an epidural injection is an injection of steroid medicine into the spine right where the herniated disc is. And really what the epidural does is it reduces inflammation at the herniated disc and on the nerve root next to the herniated disc to treat leg symptoms as well as back pain. The thing about epidurals is they're pretty safe to do. I've only seen a couple of complications. We actually have a post on a complication from an epidural. If you look at Deuk Spine Institute's YouTube channel and go to Spine Scams Exposed, we had a patient who did have an epidural in her neck and she got paralyzed afterwards. Not from us, from another doctor in the area, a pain clinic, okay? So epidurals can be dangerous at times. You can even get an infection. I had a patient who had an epidural a week before he came here and ended up with a spinal infection from the epidural. So epidurals can cause complications that are dangerous, but you know, I would say the vast majority that are done are very safe, and they do cause some weight gain that's temporary because of the steroid. They can cause some irritability that's temporary because of the steroid. They can raise your sugar. If you're diabetic, you want to be careful. Hey, we're almost done. Everything's going well. I don't know how we got in. It's nothing less than a miracle, honestly. Just got really lucky. So I don't know if that answers your question about the epidural, but for the most part, they're very safe. There are literally probably hundreds of thousands of epidurals, maybe even more than hundreds of thousands. Could be millions done worldwide every year. And the complication rate is just very low. And it does help the disc pain, and it does help the nerve irritation pain. But it won't cure them. It'll only temporarily alleviate it. But I like epidurals because when a patient comes to me with a painful disc in their back, and they've got back pain and leg symptoms, we do an epidural and they get better, even though it's temporary. That tells me that their problem is an inflammatory problem. It's the disc. But the epidural will not cure the disc inflammation. This surgery is the only surgery and treatment in the world that actually gets rid of the inflammation. You almost got me. The inflammation in the tear in the disc. All right, so Deuk Spine Institute, we've created some videos that you should go watch on YouTube. The first one, why don't you run it for us, Diego? Why don't you run us the what causes the back and leg pain video, so people can see how the annular tear causes inflammation or gets inflamed from the hernia.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.
All right, well, we just rolled the video animation of what causes back pain. And for those of you that can see, if a back pain is coming from a herniated or bulging disc, it's coming from inflammation inside that disc. And that's what this surgery fixes, is that inflammation. Because we treat the source of the inflammation. It's the annular tear that's in the back of the disc, not the side, not the front, the back. So if a disc has tears on the annulus, on the front, sides, and back, only the tear in the back is the one that causes back pain. Because only the tear in the back has somatic afferent pain fibers that go up to the brain, and the brain is able to perceive it as localized pain in the back because it projects to what's called the primary somatosensory cortex, as you saw in the video. That's very important. That's one of the big discoveries we made at Deuk Spine. Everyone thinks back pain is non-specific. You'll see it written up that way as non-specific back pain, but it actually is very specific to the lower back and specifically to the disc, as long as it's the posterior annulus that's torn and injured. So by treating the posterior disc herniation that's painful and inflamed, we can get rid of back pain permanently. Now, this patient not only has back pain, but she's also got leg pain. I need 5 minutes. So she's got back and leg pain. And those are the end plates of the bone. This is lateral in the disc, lateral in the foramen. Really not much disc left here at L5-S1. A lot of inflammation, as you can see. Yeah, just about done here. Just about done. This is it right here. This is the last of the herniation. Starting to get some foraminal ligament fibers right there. And that means at 12 o'clock you'll see foraminal ligament and fat. And that means we're pretty much done with the herniation. But I do want to make sure I get it all. Just near the nerve root now. The nerve root is protected still by the tube. And that's the fibers right there, the annulus. A little bit of fat. And that's it. I've done just about everything I can do at this point. And I've removed the herniated disc. This is just a piece of that herniation right here. Just amputating it right off. This is heading off to the side. Very scarred up, calcified, with dystrophic calcification. Grab her. And just about done. What a mess, huh? Let's see that. Maybe 2 minutes, doctor. Oh. Huh. Hold on, Louis. I'm getting a little more out of that crack right there.
We have more questions from Facebook.
Yeah, bring the questions.
Yeah. Does the doctor do more than just laser surgery?
Yes, Dr. Deuk does a lot more than laser surgery. Dr. Deukmedjian, me, I'm a board certified neurosurgeon, trained at the University of Florida in Gainesville for residency. And in my training time, spinal fusions were big, really, really big. Back at 2000, basically 2000, 20 years ago, 21 years ago, I was learning the most advanced fusion techniques. And in 2004, from 2002 to 2004, we were putting in artificial discs. We were one of the first places in the country to put artificial discs in the United States. And so I was doing fusions and artificial discs. And that's really all I did for years. I've done over 1,000 lumbar fusions in the lower back with screws, rods, cages. And my results have been published. If you go to PubMed, I've published papers on spinal fusions. If you look up Deukmedjian, Ara Deukmedjian, myself, my brother is also a neurosurgeon. He's published as well on spine surgery. And then for cervical, I've done over 1,000 anterior cervical fusions, ACDF. And I've done over 500 posterior cervical fusions, big screws and rod cases. So I'm a very big spinal fusion doctor. I was a big spinal fusion doctor for many, many years. And then once I perfected this laser technique, this Deuk laser disc repair, I really realized that we got better results than with fusions. And the patients went home right away. And they didn't have pain afterwards. And they didn't need painkillers. So it was amazing. I pretty much have stopped doing spinal fusions as much as possible. I don't do them anymore unless it's absolutely the only thing that'll work, like this case we did today, earlier today, where I did a C1, C2 fusion for cervical instability at C1, C2. And that case went perfect. You've never seen a fusion done like that. You never will see another one. Just go back and look at YouTube. It was basically bloodless surgery. I lost 5 milliliters of blood.
That's all, please.
And but we're not getting any suction on the line, guys. We need suction on the line. You may not be connected. I think you've got the bag connected, but this one,
This already.
this one here. Yeah. See it? Okay, good.
I need more irrigation, please.
All right, we're done with the scope. We're done with the surgery. Scope off. We're gonna irrigate down here with a little antiseptic called betadine, developed by NASA. And betadine was taken into space by the astronauts to protect them from any microbes that they could potentially bring back to Earth. And we're talking Invasion of the Body Snatchers kind of stuff. How many people know that movie? Anybody seen Invasion of the Body Snatchers? No, that's an old one. Right? Oh, it's amazing. It might be right. Huh? Oh, I don't know. What do you think? Maybe. We're all done. You did great. We're just getting everything out here. Like I said, it's tight because she has so much arthritis around the facets. So, it's up to you, Luis. Just take a look at it if you think it needs it. You got it?
I got it.
All right, hey, let's show the audience how small this incision is. Look at the size of this thing. The whole surgery was done through that. Look at this old scar from her scoliosis surgery. I didn't do the surgery, but look at this. Can you see this, Diego?
Yes, we saw both.
It literally goes from here to here, and it actually goes up her whole spine. And you saw she still has horrible scoliosis. So that whole scoliosis surgery, and she still has pain, and we just fixed it with the laser. Alrighty. I'll come answer your questions, so feel free to type them up. I'll come do a quick interview with you.
Deuk Laser Disc.
Great job, everybody. Thank you so much for all your help today.